Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a cataract with Coloboma iris. Nuclear sclerosis in this case is about grade 3. I have taken up this case for surgery. Let us observe the surgical steps. This is the main incision on the posterior aspect of the limbus with a 2.8 mm steel keratom, and now 2% hydroxypropyl methyl cellulose is injected into the anterior chamber. Now watch this. A side port is made at 7 o'clock and the size of this side port is about 2 mm. I will use this side port for superior sphincterotomy. This is another side port on the left side of the main incision, and this is a small side port of about 1.5 mm. And now a capsular tag is raised. I hold this capsular tag with the Utrata forceps, and rhexis has to be done very judiciously in this case, so that margin of the rhexis is at equal distance all around from the visual axis. We cannot take guidance of the pupillary margin in this case because of the Coloboma iris. So we have to do the rhexis very judiciously, and it has been a very satisfactory rhexis of about 5.5 mm. And now hydrodissection is done. Fluid wave goes to the opposite side. Hydrodelineation is attempted, and hydrodelineation has produced a beautiful golden ring in this case. The nucleus is rotated nicely several times, and now is the time to introduce the tip of the phaco needle into the anterior chamber. And here goes the tip of the phaco needle. The machine being used is Faros from Ophth, Switzerland. A beautiful machine, and here it is. The tip of the phaco needle goes into the anterior chamber. Some superficial cortical lens matter is removed. Handpiece is turned, bevel is made up towards the cornea, and now watch direct chop. The tip is buried into the substance of the nucleus. The hardest part of this nucleus, the center, is held very firmly, and the nucleus is chopped. So whenever it is in grade 3 nuclear sclerosis, or grade 2, or between grade 3 and grade 2, you can hold the nucleus very firmly at the center and chop the nucleus with your chopper. Train the delicate muscles of your hand. It is not the chopper that divides the nucleus. It is your judgment and movement of the delicate muscles of your hand that does the job. So nucleus and epinucleus has been managed, and now the phaco needle is removed, and the anterior chamber and the capsular bag is filled up with visco. And now I am using a 23 gauge Simcoe cannula going through the 7 o'clock side port and remove the cortex from the superior aspect. And the cortex from 4 o'clock to 9 o'clock has been removed. Now I go through the main wound and remove the cortex from 4 o'clock to 9 o'clock. At this time we have to be very careful because jonular dialysis may occur. The jonule may be weak at the site of the coloboma, but fortunately There is no zonular dehiscence in this case. Cortical cleanup has been done very nicely in this case. There is no cells anywhere. And now visco has been injected to fill up the capsular bag and the anterior chamber. And in this case, I'm going to use a B cartridge. So I'm going to enlarge the main wound by 0.2 millimeter. So the main wound, which was 2.8 millimeter, is now 3 millimeter. And injection of the lens will be very easy with the B cartridge because I have enlarged the main wound. And now here it goes. The lens goes into the capsular bag. And now the lens is dialed. The haptics are placed at 3 o'clock and 9 o'clock. And there is nice overlap of the optic of the IOL by the rhexis margin. And now in this case I have planned superior sphincterotomy. To do that, I want to constrict the pupil, and to constrict the pupil I need to remove the visco very nicely. So I am removing visco from anterior chamber, from the capsular bag, using both Simcoe cannula and bimanual irrigation aspiration. And now here it is. Simcoe has been used. Now bimanual irrigation aspiration is being used to remove the residual visco. If there is lot of visco, pilocarpine may not be efficient to constrict the pupil. So my idea is to remove visco very nicely, inject an air bubble, and then apply pilocarpine. This is a real-time video, totally unedited, so I am going to show everything. Now this is pilocarpine. Pilocarpine is being injected all around, but as I injected pilocarpine, air bubble, a portion of the air bubble came out. So what I am going to do now is inject air bubble again and inject visco from the 7 o'clock side port, and at this time I am injecting visco only in the superior part because I need to constrict the iris sphincter pupillae of this part, the 11 o'clock to 1 o'clock part. And now I'm waiting for some time, and we can see that the pupil is constricting very well. Now once the pupil gets constricted well, I'm going to inject visco again, and I'm going to use a vitreous scissor, a scissor which is used in vitrectomy, to do the superior sphincterotomy. Why we should do superior sphincterotomy, I'm going to mention that in a short while. So I have waited for quite some time, and now I'm going to inject visco so that I can use a scissor in the vitreous cavity. Here is the visco 2% SPMC, and the air bubble is replaced by this visco. And now I ask for the vitreous scissor. Go through the 7 o'clock side port, which is about 2 millimeter in size. The patient is under topical anesthesia, and here it is. This is superior sphincterotomy, just one cut. And now, as I am going to remove the visco again very nicely, let me explain why we should do superior sphincterotomy in cases of Coloboma iris. I have done this in more than, say, maybe about more than 25 cases in the last 15 years of my practice, and all patients are doing well. They are very happy. The reason I do this superior sphincterotomy is when the people is of normally of normal size in Coloboma iris, the upper part of the pupillary margin comes very close to the visual axis, and in some cases the visual axis may even be obstructed partially by the upper part of the iris. So if we just make one snip like this, the pupil will go upward and the visual axis will be unobstructed. This is the reason I do this superior sphincterotomy. All patients are happy, and these patients are habituated to this shape of pupil. We need not reconstruct the pupil and make it round. And now this is a bit of moxifloxacin, and now we have to close the side ports. Corneal stroma on either side of the side ports are hydrated with BSS. The stroma becomes thick and the openings get closed. So we are towards the end of the surgery. A final lavage of the anterior chamber is done. And this is very important to prevent TAS, toxic anterior segment syndrome, this final lavage. I have not faced a case of TAS in the last 10 years, and I strongly think this is because of this final lavage. Just leave pure BSS in the anterior chamber and conclude the case. Thank you very much for your attention. Hope this video will help you in developing your surgical skills, and you will get the idea of doing superior sphincterotomy with a scissor in cases with Coloboma iris.